Nice to meet you all. Very nice to be in Athens again. My name is ALON SCHNEIDER. I'm coming from Israel. Every time I'm coming to Greece, I've been to Greece many, many times. I think to myself that if you want to be a doctor, you need to learn Greek because you can understand so many things. And then when I'm going to Italy, I'm saying this thing about Italian and about Latin. So I have my own clinic based in Tel Aviv, and this is my team. This is probably one of the slides that I'm most excited about. And our clinic is focusing on regenerative therapy in different parts of aesthetic medicine. And our primary subject is hair restoration, non-surgical regenerative hair restoration, but we always use regenerative therapy in skin health and facial rejuvenation, and orthopedics, and also in gynecology and in different fields of medicine. But today we are into speaking about hair loss. Just like in many other diseases, especially chronic diseases, hair loss is here to stay. And it's here to become even worse. Why? Because we live in a world that is very, very stressogenic. And we know about the correlation between stress and cortisol levels and hair loss. So I can tell you about myself. As you can see, I don't have a lot of hair. I'm like this since the age of, let's say, 21, 22. I clearly have genetics. I'm going to show you. I have one slide about that. I clearly have genetics. But according to my genetics, I was supposed to get bald around 30, 35 maybe. I'm 40 now. I got bald 10 years earlier. Why is that? So I was in the army, in the Israeli army, 4 years of very difficult and stressogenic work. And this is why I got probably bald 10 years earlier. And the world is becoming more and more stressful. So we are becoming more and more bald. And I can tell you about my experience with the Israeli market. The Israeli market is asking more and more for a non-surgical solution and more regenerative solution. And the clinics in Israel that got into the field of regenerative therapy for hair loss are the ones that are most profitable today. Less and less people go to do hair transplantation. More people try and ask for regenerative therapy. So the first part of my talk will be a bit about biology, the biology of regenerative hair loss, and what are we targeting when we're doing the different types, modalities of regenerative therapy. So we're all familiar with the 50% rule, and this is the problem with hair loss management and the diagnosis. So we diagnose hair loss when the hair loss becomes something like 50% of the scalp. Only then we can diagnose externally hair loss. But the problem is that when you have a 50% reduction in hair width, then you have a chance of 50% to restore it. So we need to focus a lot about patient education. Patient education means that we tell people, if you're 18 years old and you have a bald father and your older brother is also bald and your grandfather is bald, think to go to a doctor when you're 18 to do a trichoscopy, because in microscope we can see your baldness before you can see it outside. And then you can treat it easily, less costly, and you can actually keep your hair. If you're coming, like myself, to the physician, and I can show you my trichoscopy later on, nothing much to do. So we need to focus a lot about patient education to come to our clinics early in life and to try to diagnose the different factors that do contribute to our future hair loss. So on the left side, this is my father with my mom. In the middle is my grandfather. And on the right side is my brother. As you can see, my brother has full hair. My dad and I are very similar, and I'm also very similar to his father, to my grandfather. This is how I used to be as a kid, as a baby. I was born without a lot of hair, and then when I was a kid, I had a lot of hair. And you can see me when I was much, much bigger. I had some hair in my head. In this photo, how many miniaturized hair follicles do you think I have, approximately? Try to guess. More than 50%. More than 50%. And I didn't think that I'm becoming bald. But more than 50% of my hair was miniaturized by then. Few years later, this is how you can see me now, okay? It's funny, I talked to Dr. Antonio before. How do we know that we are trichologists, that we're dealing with hair? Because we are both traveling with our microscopes. So without a trichoscope, and it can be, so this is the hair metric system, the Canfield hair metric system that it's really difficult to travel with, but your pocket trichoscope is probably your best friend in dealing with hair loss problems and diagnosing them. And you can have a lot of information from trichoscopy, both on the type of hair loss and, of course, the severity of the disease and actually the prognosis that we can give to our patients. And you can see that with the microscope, we can identify the mature hair cells, so the terminal hair, and different types and different severity of miniaturized hairs. And of course, it's important for us to know how many vellus hair there are, because we know that vellus hair that are smaller than 30 micrometers are not regenerating very well. We can affect mostly the miniaturized hair, not so much the vellus hair. So what are the clinical entities that you're dealing with? Usually, if you're not a dermatologist, and I'm not a dermatologist, I'm not treating the scarring alopecias. So I'm not really treating the central centrifugal cicatricial alopecia or the FFAs. I can treat those patients in the stage of remission of the disease. When the patient is in remission, then we can start to regenerate. But other than that, I'm not really trying to control the inflammation with regenerative tools because it's irrelevant to these kind of pathologies. But the non-scarring alopecias, you can have a lot of influence there and a lot of things. So most of your patients will be probably the male and female pattern hair loss. We call them pattern hair loss because they have specific patterns. Of course, in males, you have receding hairline and reduced volume in the crown region. In the female pattern hair loss, you have the widening of the central scalp. And I don't know what about you, Antonio, but in Israel, we see a lot of those DUPA patients, a lot of male patients with diffuse unpatterned alopecias. So these are male pattern hair loss, DHT-driven, but they're more diffuse in pattern. So we cannot only take a look on the pattern and say this is male pattern, female pattern. Sometimes it can look even like telogen effluvium in males, but this is actually DHT-driven, and it's diffuse unpatterned alopecia, or what we call DUPA. And we know that the hair follicle has different stages of in the cycle. The anabolic phase or the anagen phase is the growth phase. Afterwards, the hair follicle goes into catagen. During the catagen phase, you have an apoptotic action of cells, and then the hair follicle is detached from its bulb and starting to travel up through the hair canal until it reaches telogen. In telogen, it simply rests and stays there until you have the exogen phase. And nowadays, we know about a new entity called canogen. Canogen is the empty phase of the hair follicle. It's the stage between telogen and early anagen again. And we know today that in male pattern hair loss, most of the pathologies are dealing with not only with decreasing time of anagen and increasing time of telogen, but increasing the length of the canogen phase. And we know that both PRP and stromal vascular fraction, the two modalities that we're going to talk about today, can influence the canogen phase, can actually reduce the time of the canogen phase. And I think for me, it's very, very exciting. So we know about the different pathophysiological patterns. Testosterone is being reduced into dehydrotestosterone using the enzyme 5-alpha reductase. We have in our scalp different regions, ones that are more susceptible to DHT and ones that are more sensitive to DHT. As you can see, I have hair on the temporal part and on the posterior part, but I don't have hair on top because you have different susceptibility to DHT. And of course, we know about the different factors that can influence the hair cycle, like hyper or hypothyroidism and iron deficiency anemias, avitaminosis B, D, hypercortisolemia, so different stress levels, and of course, ketosis. We have a lot of patients in Israel that are doing ketogenic diets, and they go in and out of ketosis all the time because it's really difficult to stay on ketosis all the time. The going in and out of ketosis, this is what causing stress and hair loss or hair shedding. Up until a few years ago, we used to think that hair loss or female and male pattern hair loss is a hormone-driven problem by its core. Nowadays, we know this is not true. So hair loss has historically been viewed as mostly hormonal-driven. Now we know that AGA, androgenic alopecia, is increasingly recognized as a chronic disorder of regeneration. So you have lack of regeneration of hair follicles and increased degeneration of the same hair follicle. We have progressive follicular miniaturization, which is basically atrophy, impaired stem cell activation, which is basically tissue senescence, altered microenvironment of the scalp, chronic low-grade inflammation that the previous speakers spoke about, perifollicular fibrosis, and reduced vascular support. All of these are contributing factors to the severity of the disease and, of course, to the outcome. And we need to always remember that hair follicles do not disappear. They gradually lose their ability to regenerate, and this is the main problem. So when we are trying to think about solutions, we need to tackle the regeneration part. If we understand regeneration, and if we provide not only the best regenerative solution, but a regenerative solution that comes in the right moment of the protocol, there we can actually influence and having hair growth. We know about the, I think what is most exciting about the dealing with hair, that it's kind of like, it's an organ inside of an organ. It's a small organ called the hair bulb inside of the scalp or the skin. So we know that it's a complex regenerative unit. It has the bulge region and it has the dermal papilla. The dermal papilla is the mastermind of the hair. It tells you when to start anagen, when to start the catagen, when to start regenerating, and when to stop. And the ones who's doing the real job is the bulb region, which is the primary reservoir of epithelial stem cells and produces the follicular regeneration during each cycle of hair. We have the dermal sheath, which is the supportive architecture part of the hair, and it contributes to the progenitor cells during regeneration. We have the matrix keratinocytes, which are very, very rapidly progressing, proliferating cells responsible for the production of hair shaft and the hair proteins, and of course the sebaceous glands, which produces sebum, which is a very important key element in follicular homeostasis. When people ask me how many times I need to shampoo my hair per day, because in Israel, because it's hot, like in Greece, many people wash their hair 3 times a day. When using shampoo 3 times a day, you are stripping your scalp from the sebum, which is the protective layer of your scalp. And this is part of the bioenvironment. It is very, very, very important to keep. Some patients, we do trichoscopy and we see there is a hypersebum production. This is also not good. So we can use different products like ketonazole shampoos to reduce the sebum production and inflammation. And we can always, I do it a lot in my clinic. We use different keratolytic peelings before hair treatments to reduce a bit the sebum production of the scalp and to actually help the regeneration process. And very, very important is the perifollicular vascular network. So if we have a good blood flow to the scalp, we have better regeneration. Why minoxidil is such a good medication? 2 reasons. First of all, is a vasodilator, right? It increases the blood flow. Of course, it also produces more signals to keep the hair in anagen, in a complex biochemical process that we're not really sure what it is, but for sure it's a vasodilator that helps promoting blood flow to the scalp. And the successful hair growth depends on the communication between all of these, between the stem cells and the dermal papilla cells and the fibroblasts and the adipocytes and the immune cells and the endothelial cells. This is an orchestra of events that a good communication between the different players will give you a best regeneration of the scalp. So we know that in health, the hair growth is a continuous regenerative process. Unlike most organs, the hair follicle undergoes repeated cycles of degeneration and regeneration. And the problem in androgenic alopecia, I'm going to show you here, that you have a shortened anagen phase, prolonged catagen phase, and telogen phase, and nowadays we know that we have a prolonged canogen phase, and the canogen phase is very, very important. So we know I talked about the DHT problem. This is something that we're very much aware of, but we also have in androgenic alopecia dysregulation of inhibitory signals. So we produce a lot of those DKK1 and pro-inflammatory cytokines and TGF-beta, and we produce less pro-growth signals, like vascular endothelial growth factors and IGF-1 and fibroblast growth factors. We know a lot about the WNT beta-catenin signaling pathway that is reduced significantly during androgenic alopecia, and all of this results in loss of regenerative signals. Also, we have the microinflammation. I'm going to show you a slide here with inflammatory scalps, how it looks like. And if you do histology, and in Israel, we love to do biopsies of the scalps for some reason. I don't know why. It's not really diagnostic, but yeah, whatever. We can show a lot of perifollicular lymphocyte infiltration and increased cytokine production, a lot of oxidative stress on the scalp. All of these will give you a resistance to regeneration. Perifollicular fibrosis is the result of chronic inflammation, and it produces a lot of collagen deposition, and of course, some pictures looks like PIH, like post-inflammatory hyperpigmentation, because of this chronic inflammation, and this impairs follicular regeneration. And as I said before, the vascular dysfunction is a very important key element in the pathophysiology of hair loss. So take a look on one of my patients, and I took two microscopy pictures. One is in the center of the vertex, and one is a bit to the periphery of the vertex. What can you tell me about this picture? This is very important. Look at the color, look at the different signs. So this is a chronically inflamed scalp. We have signs of pigmentation. So this is what I told you before. It looks like PIH, like post-inflammatory hyperpigmentation, which is basically the result of this fibrosis of the scalp after a long time, many, many years of inflammation. We can also see, you see those white dots? These are follicular units that were miniaturized, became vellus hair. The vellus hair is so thin that it cannot go out of the ostia of the follicle, and the ostia is becoming full of sebum and getting blocked, right? So this is one of the most important pathognomonic signs of androgenic alopecia. But if I'm going a bit to the periphery of the vertex, I can see that I still have active follicular units, and the different colors are basically these are the diameter of the hair follicle. So if you see follicle with green, these are hair width of about 90 micrometers. The light green is between 60 to 90, so a bit miniaturized. The yellow ones are 30 to 60, and the red ones are vellus hair that are smaller than 30 micrometers. Now, where regeneration happens in the follicular niche. So the hair follicle do not function in isolation. I told you before, we cannot tackle one part of the hair follicle in order to get regeneration. We need to tackle the orchestra. You cannot tackle just the violin. You need to deal with the whole orchestra together. So the ability to cycle, to regenerate, and to maintain terminal hair growth depends on the continuous communication with surrounding cells and extracellular matrix. This is why regenerative therapies are not a single treatment line. You need to give a continuous treatment for few hair cycles in order to get any improvement. And this is something that we need to remember when we're working on building our own clinical protocols. The major components of the follicular niche are, of course, the stem cells within the bowel region, the dermal papilla. These are the two most important communication. The fibroblasts, that they're producing the ECM, the extracellular matrix, that support the tissue remodeling, and the adipocytes, which have active endocrine secretions, and of course, the secrete growth factors, something that is very important in nanophenotyping nanoFET grafting, the endothelial cells that maintain vascular support, and the immune cells that will regulate the inflammation. And the regenerative niche becomes progressively dysfunctional with the decrease in stem cell activation and dermapapilla signaling, decrease in vascular support and adipose-derived growth factors, and increase in inflammation, fibrosis, and inhibitory cytokines. Now, nowadays, we understand, as you said before, about the three types of aging. You have the chronoaging, you have the inflammaging, and you have the sun aging, what we call it. And in countries like Greece and Israel, we have a lot of sun exposure, so of course, solar aging is very important, but the inflammaging is becoming more and more recognized as the main problem. So when you have a perifollicular lymphocytic infiltration and increased oxidative stress and elevated inflammatory cytokines and destruction of follicular immune privileges, then you have chronic inflammation, chronic inflammaging of the tissue. It's true to the hair, it's true to different parts of the body, and of course the skin. And the key cytokines are TNF-alpha, IL-1, IL-6, and TGF-beta. The clinical outcome will be shortened anagen and increased shedding and, of course, reduced regenerative capacity. This is, I talked about it before. What is the opportunity of regeneration? So many regenerative therapies, they exert benefit through anti-inflammatory effect, immunomodulation, enhanced angiogenesis, and extracellular matrix remodeling. And the different modalities, they are PRP, and stromal vascular fraction, and nanoFET grafting, exosomes, that actually derivative of these two, and of course, a micrografting with Regenerative, for example. And when we are planning a treatment plan for our patients, we need always to tackle those three elements. If we're talking about androgenic alopecia, both in male and females, we need to block DHT synthesis or block somehow the receptor. So in females, especially in young females in the productive life, we don't really like to give finasteride or dutasteride. We don't really like to block DHT synthesis, but we do like to block the receptor. We can give spironolactone in low dose and to block the receptor, and this is how we actually can avoid the chronic miniaturization. You need to increase scalp blood flow, and I always like to give minoxidil to my patients, and I'm telling my patients that we don't have to use minoxidil lifelong. I like to give minoxidil mostly for the 1 year of treatment, of regenerative treatment. It supports the regeneration because it supports the blood flow and oxidation of the tissue. After this 1 year, I tell my patient that we're going to reduce the use of minoxidil topically or per os as much as we can. But the most important thing is the potent and appropriate regenerative therapy. And I think the word appropriate is the most important here, and this is something that we're gonna try, Dr. Antonio and myself, to explain today. When you need to try, when can you choose PRP, and when you need to choose SVF, stromal vascular fraction, and nanoFET grafting, because the solution needs to be appropriate to the problem. And here I'm gonna propose the concept of art of the autologous regenerative therapy. You need three pillars. First of all, you need some sort of dermal iatrogenic assault. You need to give some sort of signal of regeneration. So of course, when you have a patient with active miniaturization, you have enough inflammatory cytokines to be able to show the body that there is a pathological process. But if we do some sort of dermal assault like mesoinjections and dermapen and microneedling, then you give those signals to the scalp that you need to start and regenerate. When you do this, afterwards you need to deliver regenerative products, PRP, PRF, CGF, skin micrografts, and of course the SVF. And the combination of the iatrogenic assault and the delivery of the regenerative product will create the regenerative process. But regeneration takes time. We need to respect the latent period. I cannot call my patients on a weekly basis to do PRP. It's completely irrelevant. I need to give the inflammatory process to reduce. It takes time. I need collagen production. It takes time. And of course, I need regeneration of the hair follicle. It also needs time. So we give those latent periods of between 4 to 6 weeks between one treatment to another, and you repeat this cycle 2 to 6 times, usually 4 times. It will be the best. So, after this introduction, quite long introduction, I'm going to give a few words about PRP and what is the role of PRP in regeneration of hair. So the goal is to restore the biological conditioning that is required for the healthy follicular regeneration. And rather than simply blocking disease progression, we need to provide regenerative therapy. And this will aim to reactivate dormant follicles, to improve the dermal papilla signaling, to enhance angiogenesis, reduce inflammation, everything we talked about just before. And the ideal regenerative protocol, if you plan one to your clinic, should be able to, first of all, increase the pro-growth signaling, the pro-regenerative signaling, to improve vascularity, to reduce inflammation, to reduce fibrosis, to enhance stem cell activation, and to restore the follicular communication. When you're planning your protocols, you need to consider all of those. And the regenerative solutions we have today are two types. We have the cellular ones and the acellular ones. So acellular, non-cellular approaches will be, of course, the PRP. PRP, platelet-rich plasma, the PRF, the platelet-rich fibrin. The difference between the two is that PRP has more platelets, but it stays less time in the tissue. PRF has less platelets, but it's fibrin. It stays a bit longer in the tissue because it's a bit thicker until it's getting absorbed. We have different growth factors that are being secreted, and of course we have the world of exosomes that we're going to talk about later on today. And you have the cellular approaches or the cellular modalities. You have the SVF and nanofat. We have the adipose-derived regenerative cells, and of course Regenerative micrografts. That is not the focus of today, so I'm not going to speak about much. And we are shifting nowadays between the traditional model of you have DHT, miniaturization, and hair loss, and the treatment will be to block DHT, taking finasteride, Proficia, or dutasteride, to the regenerative model. If you know that you have inflammation and fibrosis and dysfunction of signaling and stem cell problem, the treatment will be to restore the follicular ecosystem. So what is PRP? Basically, PRP is an autologous biological therapy created to concentrating platelets from the patient's own blood. And this is something that I'm coming across a lot between physicians. Many people think that you can take 10 milliliters of blood, create from it 3 to 4 milliliters of PRP, and this is the solution to all your problems in life. This is absolutely not true. So we're gonna talk about the protocol of creating PRP, and most important about the volume of blood that we are collecting. 10 milliliters is not enough, not for scalp. The platelets that we are collecting they're serving as a reservoir of regenerative growth factors that are released upon activation. We all know the Selenis blood collection tubes. They contain anticoagulant inside, right? So when we take whole blood and we mix it with the anticoagulant, we are stopping the alpha granules to degranulate and to create the cascade, right? But then we inject it into the body. When we inject it into the body, it's coming across different tissue factors which will activate the platelets, which will then release the alpha granules, and the regenerative process will start. And what is inside of the platelets? So the platelets contain alpha granules that are containing very numerous bioactive molecules, including immunomodulation and apoptotic signaling, antifibrosis, chemotaxis, proliferation, so on and so forth. But the most important growth factors will be the platelet-derived growth factors, the PDGF, the vascular endothelial growth factors, the epidermal growth factors, the fibroblast growth factors, and the TGF-beta. Additionally, there are different mediators like other cytokines, chemokines, adhesion molecules, and extracellular vesicles. Extracellular vesicles or exosomes are being created by the platelets all the time. You don't need a specific kit for that. If you want to increase the number of exosomes, then you need a specific kit because you need to give some sort of stress to the platelets. And those signals promote follicular activation. They prolong the anagen phase. They create a premature exit from telogen back to anagen again. They have a dermapapilla cell proliferation activity. They, very importantly, increase the beta-catenin WNT signaling. They activate the bulge stem cells, and they improve follicular angiogenesis. In the bigger microenvironment, scalp environment effect, they give you better oxygenation, improve nutrient diffusion, ECM remodeling, which is very important in fibrotic scalp, reduced fibrosis, and improved graft survival after transplantation. Now, we have a lot of clinical data and preclinical data about the action of PRP, but there is one main problem. The studies are not strong enough. Okay, they're not really standing within the world of evidence-based medicine. And the question is why? Is PRP a bad solution? Not at all. Because we don't have a standardized way of creating PRP. And we cannot compare one patient to another, one study to another, and we don't really do enough split scalp or split face studies. And this is something that we physicians, especially the ones that are dealing with research, need to consider. Collect as many data as you can by creating good, high-quality PRP using the right kits. Only then we can compare one patient to another, half scalp to the other, and to see the real improvement or lack of improvement in the scalp. So the problem in our world is we don't have enough evidence because we don't have one single protocol or one modality of creating PRP. I'll show you what is the main problem that we have in Israel. This is the problem. The problem in Israel that many physicians will buy a 30 cents cost diagnostic tube, and they will create PRP out of that. Now, we all know those BD tubes, right? BD is an excellent company for diagnostic tools. Their only FDA and CE approval is to collect whole blood from the vein, to put it in the lab, and the lab will have machines that will read the elements from the blood. We are not allowed to collect the blood products from those tubes and to inject it back to the human scalp. Why? Because they're not sterile enough. The anticoagulants are not medical grade for injection. They contain microplastics that will be injected and will be deposited in the scalp and will further create inflammation. So these are amazing tubes, but we're not allowed. This is completely irresponsible to take those good tubes for diagnostic and inject it back to the scalp. And this is why when I'm teaching in Israel and I'm talking to Israeli physicians, I'm trying to explain why pay almost 30 times more on PRP kit than to buy those 30 cents diagnostic tools. Because this is a matter of medical responsibility. This is a matter of good medical conduct. We are here to protect our patients, not only to make money. Okay, and this is something that we have to remember. So when you're dealing with PRP, you always need to go on CE, medical approved or FDA approved products. This is the beginning and the end of the discussion. You can see here there are a few studies, but there's one good case reports where PRP was made of those BD tubes, and then it was put in into microbiological studies, and they showed that there are a lot of pathogenic bacteria, a lot of dust, a lot of yeast, and a lot of other pathogens in the PRP, and of course a lot of microplastic. Why? Because those BD tubes are coming in a rack of 50, you open it once, you put it in your clinic, dust sitting all around, you have bacteria all over, and then you collect blood from the patient and you inject it back to the patient. Most clinics draw between 10 to 20 milliliters of blood, and this is biologically underdosing, completely underdosing. The baseline platelet count is between 150 to 300,000 platelets per microliters, and hair regeneration needs a supra-physiological platelet concentration, not physiological concentration. I'm going to show you in the demonstration. When we collect the blood in those Selenis tubes and you put it in the centrifuge and then you take it out, you have the lower part of the red blood cells, you have the separating gel, you have this plasma. The plasma is PPP, is platelet poor plasma. Where are the platelets? They're sitting on top of the gel, okay? If you want to create PRP, you don't need only to swirl the tube a few times, because then you're gonna get physiological concentration. No, you need to remove 2/3 of the PPP and then resuspend the rest of the platelets in the serum, right? This is how you create a good quality PRP. So it's not only about the volume, the total volume, it's a matter of concentration of platelets. The more the merrier. You cannot water a forest with a glass of water. High quality PRP is about the total platelet count, the total platelet dose, not just PRP as a label. And Selenis has a very, very good quality, high quality 40 milliliters system. And I can tell you in my clinic, we either use per patient 2 tubes of 22 milliliters or 1 tube of 40 milliliters. And this is the only solution that gives you results. Selenis also have 11 milliliters tubes. They're very good for skin quality and for other things, not only for the scalp. And it's more cost-benefit to buy those 40 milliliters tubes or 2 tubes of 20 milliliters than to use 4 tubes of 10 milliliters or 11 milliliters. So those 40 milliliter systems, they have higher total platelet dose and more reproducible platelet concentrations, low contamination with erythrocytes, sterile system, it's a closed system, better scalability for full-scale scope protocols, and of course, easier combination with other therapies. And the optimized treatment protocol, and this is my protocol in the clinic, is I recommend an induction phase of 4 to 6 treatment sessions spaced between 3 to 4 weeks from one to another, and then a maintenance phase of a treatment every 4 to 6 months, depending on the disease severity, the age, the ongoing medical therapy, and the clinical response. And why do we need multiple sessions? Because PRP creates temporary biological signaling. In order to affect the entire scalp, and remember, each hair in the scalp is in different time of its hair cycle. You need a prolonged treatment because you need to give those pro-regenerative signaling for a long time. So PRP creates a temporary biological signaling. A repeated stimulation means a reinforced regenerative pathway. This will maintain angiogenesis and sustain follicular activation. The typical total volume is about, after creating of the PRP, between 5 to 12 milliliters of PRP coming from 40 milliliters of blood, and this will depend on the treatment area, the hair density, and the degree of miniaturization. I inject them in 1 centimeter grids, 1 square centimeters from each other in a uniform scalp coverage. I'm not injecting only to the bald part, I'm injecting to the entire scalp, because right now, you see only receiving hairlines without any effect on the vertex. In a few years, the vertex will be affected. So you need to treat the vertex right now. And the key principle is treat the entire affected ecosystem, not isolated follicles. Regarding injection depth, and this is also true for SVF, but Dr. Amore will talk about it later on, the target structure is the dermal papilla. The dermal papilla is located quite low, quite deep in the tissue. The recommended depth is, of course, depend on the scalp, between 3 to 5 millimeters. Now, if you take your 2 fingers and try to palpate your scalp, my scalp is very thin because I have many years of fibrosis because of androgen alopecia. For me, 3 millimeters will be enough. But maybe in your scalp, you need 5 millimeters. So when you inject PRP into your patient, palpate it first. Try to understand the depth of penetration. If you have a long needle, maybe penetrating in 45 degrees is the best idea. If you have a 4 millimeters needle, maybe 90 degrees is the best idea. This is how you treat those patients. You need to understand what is the depth. If you inject too superficial, you're going to get very poor dermal papilla exposure. But if you're going to inject too deep, then you're going to have a reduced biological efficacy because you're going to inject into the hypodermis. And we don't want the material to be in the hypodermis. And the goal is to deposit PRP within the deep dermis or the superficial subcutaneous plane where the follicular niche resides. Regarding patient selection, who is the best candidate for PRP compared to other modalities? So the ideal candidates will be an early androgenic alopecia with Norwood 2 to 4, Ludwig 1 to 2 in females, or Sinclair 3 to 4 in females. And the patient should have active miniaturization with miniaturized follicular present and preserved follicular units. It should not have too many vellus hair, like you see on the right side. The younger patients produce better regeneration. We know it from skin, we know it always from hair. And this is taking me back to patient education. You need to educate your patients to come early in life, and then you're gonna get better regeneration. And of course, a combination therapy, like any other thing in medicine, is the best protocol. So you need to combine minoxidil with DHT blockers, either it's finasteride topically and dutasteride. I don't really give oral finasteride anymore because we know about the side effects. And actually, the side effects are being told to be 3%. I see in my clinic about 30%. And you know why? Because you cannot compare questionnaire-based studies between men and women. Men under-report sexual effects. Women over-report it, okay? So, but I see in my clinic about 30%. So topical finasteride and topical dutasteride are very good solutions. Who are the poor responders? The poor responders are the ones with advanced Norwood, and the ones with extensive fibrosis, and the ones with long-standing bald scalp, like myself. I'm not gonna do anything with PRP or with anything else. The ones with long-standing, with the heavy smoking because they have vasoconstriction, and the ones that are in poor compliance. If you know that your patient is not gonna come to the treatment, then don't even start. It's a waste of money. And PRP improves follicular function. This is something we need to remember. It does not regenerate follicles that are not longer exist. And it does not create follicles de novo. And this is something that we need to explain to our patients as well. So what the patient should expect throughout the timeline of treatment. So between 2 months into the treatment, we have minimal, if at all, visible improvement. But we do have biological changes which are predominant. Between 2 to 4 months, we have reduced shedding. The patients say, okay, I have less, mostly females, I have less hair shedding during the day, and improved scalp quality. Between 4 to 6 months into the treatment, we have an increased thickness of the hair and improved density, and by the 1 year of treatment, we have peak visible improvement. So it doesn't really worth taking global pictures, photography after 2-3 months. You're not gonna see much, but you will see some evidence in microscopy before. The realistic clinical outcome will be reduced shedding, increased shaft diameter, improved density, and better hair quality, and of course, slower the progression of the disease. PRP cannot achieve unlimited density. It cannot restore completely bald scalp. It cannot replace hair transplantation when needed, and it does not produce instant results. And the typical improvement, we say, is about 10 to 25% density improvement, 15 to 30% increase in shaft diameter, and these are the best responders. Okay? Yeah, I talked about it before. The best client is the most informed client. The biggest predator of satisfaction from your client is not results, but expectations. If you set your expectations right upon initial consultation, then your patient will be happy. And now I'm going to give the stage to Dr. Amore to continue talking about different solutions, and I'm going to see you later on. Thank you very much.